Hi class. I'll be going over today's presentation, which is caring for the mental health needs of special populations in our primary care. So I'm going to start with the geriatrics. We have the epidemiological data reveals that the elderly bear a disproportionate share of the world's mental disease case. Undiagnosed or with a distinct presentation of mental disease in the elderly is common. For instance, anxiety disorders might manifest as a physical alignment. In 2020, there was a research made by Bahardi and Pawan found that sedentary lifestyles, which included smoking and not getting enough exercise, are directly and indirectly linked to poor mental health. In order, one second. In order to the older persons. So major depressive disorders, DSM-5 criteria. You see major depressive disorders, also known as MDD. Per the APA in 2013, more of the following, you have to have 5 or more of the following symptoms should be present within the same week. So it should be something like if the person has depressed mood, loss of interest, no pleasure, weight loss, weight gain, insomnia, hypersomnia, psychomotor, agitation, retardation, being tired, feeling worthless, decreased concentration, thinking of death, suicidal thoughts. Diagnostic criteria continues. Extra standards that must be met must exhibit at least 5 of the depressed symptoms in addition to the 4 listed below. Symptoms significantly impacted of social, vocational, or the other crucial aspects of functioning leading to clinical distress. An episode that cannot be explained by the way or a drug or health issue affects the body. An episode that occurred be well described by any of the psychotic disease or schizophrenia. For the treatment plan of the elderly, it is essential to check blood work like CBC, CMP, thyroid blood work, providing information on medication, seeking to reduce potential sources of stress. This may be impacted for external pressures or not. I would prescribe Solo 50 milligrams, talk therapy, medication, antidepressants. 2 to 4 weeks later, meet again to follow up to see if there's any medication side effects, any suicidal thoughts that they're feeling. Let the patient know that it is crucial for them to let us know if they experience any suicidal thoughts. For the prenatal lactation population, that will be early postpartum. It is crucial for the mother and the baby to make neuroendocrine shift from pregnancy to nursing. Failed breastfeeding and prenatal mood disorders are 2 significant therapeutic issues that develop during the phase in a clinical setting. This illness so basically is failure to receive any prenatal care, which happens to a lot of mothers that don't have money, that don't have health insurance. Those are the people that will fall into that. According to the recent American Journal of Public Health report, untreated maternal, prenatal mood, and anxiety disorders have significant financial impact. The cause of untreated prenatal mood or anxiety disorders for the 2017 cohort was estimated research to be $14 billion, with average of per mother child pair with a postpartum disease. So, diagnosis criteria: a lot of women go to postpartum depression. We know that. That's why we need to take care of a pregnant woman. According to the diagnostic statistical DSM-5 criteria, a woman must exhibit at least 5 of the symptoms. So anxiety. In the prenatal era, anxiety symptoms may be almost prevalent to depression. Some treatment that we could do will be careful questioning our pregnant or prenatal woman and physical examination, complete medical exam, medication review for PHQ-9, baseline blood work, CBC, CMP, TSH, lipids, pregnancy test. If we do find out she's pregnant, we also want to test her for STDs to make sure that the baby will be okay. Some medications that will be safe for pregnancy will be solo, daily. In America, depression is becoming more common among young people. And that's where we have seen that a lot of young people have attempted suicide. A lot of people go through bullying. A lot of kids go through a lot that we don't know, and we have to be aware. Well, us as future psych and peace and nurses that we are, we know that kids go through a lot, and nowadays it's even harder. Children, families, and society will bear heavy financial price due to childhood mental illness. According to Davis, the annual cost of childhood mental problems in the United States is almost $10.9 million in children. Imagine that. So some of the DSM-5 diseases that affect our kids will be the autism spectrum disorder, ASD, which includes 4 diagnoses. Then we also have ADHD, which is a behavioral problem. Plan for treating ADHD is behavior management, education of our parents, getting them a behavioral health therapist to help them with their behavioral issues. And if it comes to the point that the parents need to put the child on medication, that will be the parent's choice. LGBTQ population, people who identify as belonging to a sexual or gender minorities are more likely to encounter some mental health problems. A lot of them suffer from depression, anxiety, abuse. With the support of their families, communities of LGBTQ, highly resilient. If a person of the gender expression does not match their biological sex, they may be diagnosed as gender dysphoria, a mental illness according to the DSM-5. They were given a diagnosis at birth that they're going through a very difficult time, socially and professionally, depression induced by substances or medications, associated with suicidal thoughts, and major depressive disorder, generalized anxiety disorder. Treatment plan will be promote self-awareness. I'm assuming one of the treatment plans for this will be also getting them through become transgender through the sex that they really want to be, helping them with that, supporting them with that, referring them to an endocrinologist to get them in the correct hormones that they have to be, getting them the correct hormone medication and hormone replacement. And it's everything about having the right plan for them, whatever makes them happy and takes that depression and anxiety away. Of course, the treatment plan will also be putting them on a medication that will be safe for them to be treated with the depression and anxiety and all those thoughts they get. Immigrant workers. The number of people seeking refugee status as well as immigrants in the United States, according to the epidemiology, 4.7% Americans were foreign-born in 1970. In 2019, 13.1% of the population foreign-born among the many girls of the United States. That's a lot. Financial expenses. The National Institute of Mental Health reports that racial and intermediary groups in the States are not have access to mental health services because, of course, they don't have insurance, they don't have resources, they are afraid to seek help, so they will really go through it by themselves, which is not healthy. There's a wide range in the frequency of mental illness among immigrants. It varies greatly depending on the factors such as the socioeconomic status, their country of origin, and the severity of the past trauma and stress. Mental health services for refugees and asylum seekers should be offered in conjunction with the many families of social and cultural supports that are already present in the person's local surrounding. helping patients build a social network and establish relationships in with the family may improve their mental health. Additionally, this will make them feel less alone. Ethnic minority groups, like people who who are like sorry who are diverse by 2044, it is anticipated that more than half of the Americans will be members of the minority group, defined as any group from non-Hispanic white alone, according to the USA Census 2015. Members of racial and minority groups in the United States are less likely to have access to mental health services. And that's true because they're coming from another country that is not the United States, and they have different costumes, different beliefs, and all plays a role into medicine. Some people believe that they're better off by themselves and that they don't need to go see a doctor. The Latino population in the United States is projected to be 18.3. Hispanics made about 16% of the population with reported mental health issues, which that's a lot. Fewer than 10% consult a mental health professional. Like I said, being a Hispanic myself, some Hispanic people think it's that nobody should be sad, nobody should be depressed, nobody, they don't believe in mental health like they should be. Medical professionals like us should think about 3 things before starting a mental behavior treatment: observing and being aware of the cultural variations, similarities among the people, without assigning any significance to them. Keep your assumptions about someone's cultures to a minimum. Provide resources to bolster the intensity and culture. Provide translation services as needed. And here's my references, lovely class. I hope you guys have enjoyed, and thank you for your time. Bye.